two of my young colleagues, but they are now stalwarts in respiratory medicine all over India, Raja Dhar and Dr. Shelly Samim. Dr. Shelly Samim will cover the asthma part and Dr. Raja Dhar will cover the COPD part. And for total coverage and also the focus, we'll have a short introduction about obstructive airway diseases. So it may seem very superficial, but for someone who is like me at the back bench of the class, whenever we talk of obstructive airway disease, we practically mean expiratory airway obstruction. Because with inspiration, the thorax expands, there is negative pleural pressure, pulling out the lungs out. So any airway will be broader in diameter during inspiration and will the opposite happen, constriction during expiration. So any obstruction in the wall or in between the wall in the lumen will make further airway narrowing during expiration. Why should we devote at least 1.5 hours to this? Primarily because of the epidemiological burden. It's a huge burden. Actually, still we are not very aware of it. Both asthma, COPD, chronic obstructive pulmonary disease, and the vast chunk, which is not exactly defined even in scientific circle, the combination, innumerable permutation combination of expiratory airway obstruction. Those who are interested, they can go to the net for this global burden of disease data, Indian study in search, and Indian Chest Society, National College of Chest Physicians joint guidelines on COPD and asthma. Fortunately, NOBI has played important role in formulating all these three. Now, the airway obstruction characterized by breathlessness, wheeze, cough, and sputum have been known since the time of Hippocrates. But the conscious differentiation between two sets at one spectrum is chronic bronchitis and then COPD, and the other spectrum is asthma. This conscious differentiation is practically a product of the late 20th century. What you are seeing is the Venn diagram, and this is something historical. Actually, Venn diagram is not only for this, it has been applied in multiple streams of science. So, and this started the scientific road in understanding COPD and airway obstruction. As you can see, the degree of overlap between the different entities. So how do we diagnose asthma if we ask this in a class exam and you are given the option of everything, history, clinical exam, spirometry, response to therapy? Probably everybody contributes to some extent, but ultimately how do we diagnose asthma is variable airflow obstruction. That was the understanding at the beginning. Now we know asthma is itself a very heterogeneous disease, but we have to come something concrete. So variable airflow obstruction means at any point clinical examination may be normal. So a combination of all this, and again, the Bible is GINA, Global Initiative for Asthma.
So slide sharing with a name.
Slides nahi screen? কি ব্যাপার স্ক্রিনে স্লাইড নেই হোয়াট ইজ হ্যাপেনিং কি করছো কি তুমি কোথায় দেখো স্লাইড ওকে ওকে ডান শেয়ার স্ক্রিন এটা সালি এতক্ষণ ছিল না না
হ্যাঁ
ওই স্টার্ট পর্যন্ত ভেরি বিগিনিং
না না কনসেপ্ট আপনার ক্লিয়ার আছে এখন আমার মনে হলো তখন আপনি ইউজ করছেন স্লাইড সেই জন্য আমি বললাম
হলো কোথায় আনো না, আরে শেয়ার তো এবার দেখাবো। Okay, now it is visible, Sally.
Yes, sir.
Okay, so now a little about the path in coming to present situation. Practically, the late 50s, 60s, the idea was that asthma is primarily a disease of the airway smooth muscle. And so the treatment was bronchodilator and mainly oral bronchodilator. Then in the 1980s early came the inhaled bronchodilators, and it was hailed as a boon to asthmatics all over the world. It was used by asthmatics all over the world. And then someone in the late 80s discovered there is increased asthma mortality worldwide, may or may not be with the use of this inhaled bronchodilator. So something was being missed. And we went back. 1966, fiber optic bronchoscopy was devised by Ikeda. It was used in the market rampantly since the 1970s, and it get us unexpected dividends. In any case of asthma, be it intermittent, mild, persistent, controlled, wherever you did a bronchoscopy, lavage, and biopsy, we got elements of inflammation. So ultimately, our focus changed. Primarily, it was airway smooth muscle contraction, so give bronchodilator. Now we know the basis is airway inflammation, and the best anti-inflammatory in the history of civilization is steroids. So came inhaled corticosteroids. And then since 1992, ICS, inhaled corticosteroids, is still the king in the diagnosis, in the management of asthma. There have been further developments. We know now the subsets where even ICS may not work. Biologics have come, but again, this will be dealt with by Dr. Seli Samim. How do you diagnose COPD? Again, airway obstruction, all four history, clinical exam, spirometry, response to therapy. Ultimately, chronic persistent airway obstruction. And now we know a little more because of better radiological delineation and molecular biology that it's a mixture of small airway disease and emphysema. Again, the Bible is Global Initiative for Chronic Obstructive Lung Disease, GOLD. Practically, we harped on spirometry only since early 2000. So we did everything on COPD with a spirometric backup, FEV1. But then we understood that COPD is again a different disease with multiple subset and components which may not be really related to one another. So since 2018, spirometry was given only for this diagnosis part. So from 2018, COPD was first graded by spirometry, FEV1, and then grouped. So clinical part, it was excluding spirometry above. It was symptoms and history of exacerbation. Now we know this is the spectrum how COPD develops: smoking, air pollution, biomass fuel, infection, genetic part, some autoimmunity, and ultimately going to COPD. So the ultimate either confusion or clarification that you want to know, what to treat, the cause or the effect. In asthma, well, now we know, may or may not be, but still ICS is the king, inhaled corticosteroid is the king. But again, we know that it is primarily airway inflammation, which is responsive to anti-inflammatory like inhaled corticosteroids, So asthma treatment is based on inhaled corticosteroid and only SOS bronchodilator. And there have been changes now. Sally will put light on that. In COPD, still we are not very sure about the nature of inflammation. We don't know the best anti-inflammatory that is applicable to COPD inflammation. So still now we are treating practically symptomatically the COPD part. Maximum bronchodilation. LAMA, long-acting muscarinic antagonist, LABA, long-acting beta-2 agonist, or better, a LABA-LAMA combination or dual bronchodilation. Dr. Rajadhar will give details about this. So I will stop here and I will hand over to Dr. Sally Samim. Dr. Sally Samim, তুই কি associate professor Sally নাকি assistant? Is associate professor in Calcutta National Medical College. Calcutta National Medical College, and he is a very young, energetic physician who has done great work in this crisis time of COVID, and also with his coverage on obstructive airway disease. Dr. Sally Samim for approach to asthma and management. Thank you. Sally.
না ওটা তো রেকর্ডেড চালাবে
রেকর্ড চলবে yes.
So good afternoon everyone. I am going to talk on asthma. How do we define asthma? It's a heterogeneous disease, as we know from different phenotypic studies, and definitely there is chronic airway inflammation. But the hallmark is there in the symptom of wheeze, shortness of breath, chest tightness, and cough, which vary over time in intensity. The close differential diagnosis of asthma is COPD, where we see fixed airflow obstruction. Persons are having exertional shortness of breath. They do not have any symptom during rest, and they do not have any frequent episodes of attacks. Whereas in asthma, you see, whenever patient is exposed to any triggers, they have attacks of symptoms like cough, shortness of breath, chest tightness, and these symptoms may be there at the time of attack, even during rest, and in between period, they may remain normal. So this variability of symptom is a cardinal features of asthma, which differentiate asthma from other obstructive airway disease. Also, we need to elicit the variable expiratory airflow limitation from pulmonary function test and also peak flow meter. So what happens in asthma? If a person is genetically susceptible, all persons are not genetically susceptible, means all persons will not develop asthma-like inflammation if they are exposed to allergens. If one is genetically susceptible, then only if they are exposed to sensitizers like allergens, infectious like viral infection, any occupational sensitizer, then there will be typical asthma-like inflammation in the airway. The airways will be primed, they will be hyperreactive, and if they are exposed to any trivial amount of stimuli, like any small amount of allergen, or maybe exercise, maybe air pollution, cold air, any change of weather, any viral infection, smoking, even laughter, all these things can lead to a cascade of release of different mediators, and that leads to attacks with different symptoms of asthma. So that leads the variability that we find. In asthma, allergen is taken up by dendritic cell, the antigen presenting cell. They give this signal to the naive T helper type 2 cell, and this naive T helper type 2 cell then develop to T helper type 2 1, and T helper type 2 response is the hallmark of asthma, where there is release of several mediators, cytokines like interleukin 4, 13, which release or promote the plasma cell to release Ig. These Ig bind to mast cell, then subsequent release of different mediators like histamine, leukotrienes, prostaglandin, tryptase. Again, in another way, it releases IL-5, which promote the eosinophilic inflammation, that leads to release of cytokines, leukotrienes like eosinophilic cationic protein, major basic protein, and all these things can lead several changes in the airways, where we can see in the air smooth muscle, there is hypertrophy or hyperplasia, there is bronchoconstriction, along with there is vasodilatation and plasma leak, and that leads to edema in the wall. Also, there is mucus hypersecretion, and that leads to mucus plugging. There is loss of epithelium, and in long standing, there is subepithelial fibrosis. So this is the end result. The airway gets narrowed due to edema, mucus plugging, muscle cell hypertrophy, and bronchoconstriction. So inflammation lies as the major factor to produce this type of change. So anti-inflammatory agents is a treatment of asthma. How to diagnose asthma? Most of the time it is diagnosed from history. The typical symptom of episodic breathlessness, wheezing, cough, chest tightness is the hallmark. Episodic nature and variability are the cardinal features. Consider asthma if there is more than one type of respiratory symptom, means if there is isolated cough without any symptom of wheezing or shortness of breath, always think other possibilities or exclude other possibilities like upper airway cough syndrome or maybe GERD before considering this as asthma. Asthma is often worse at night. There is nocturnal symptom and there is early morning symptom. This helps us to detect asthma. Any identifiable triggers like viral infection, allergen exposure like exposure to house dust leading to increased symptom of shortness of breath or wheezing, exercise, changes in weather, laughter. If we find these triggers which can aggravate the symptom, then probably we are dealing with asthma. Consider other diagnoses. If there is only exertion or shortness of breath, which is found in COPD, chronic sputum production found in bronchiectasis, chronic bronchitis. If the shortness of breath is associated with dizziness, lightheadedness, or peripheral tingling, probably there is psychogenic dyspnea or anxiety. Any chest pain, think of cardiac cause or in pleural cause. Any noisy inspiration, means inspiratory stridor, think of any upper airway tumor, major central airway tumor, or maybe vocal cord dysfunction. So these are the differential diagnoses we have to think in from the history itself. The probability of asthma is increased if there is history of other allergy like allergic rhinitis, allergic conjunctivitis, or eczema, any childhood history of onset, any family history of asthma allergy. So these histories should be taken properly. Physical examination reveals bronchi, but it's often normal. As asthma is episodic, so in between period, patient may have normal chest auscultation. Also, in severe exacerbation, often we find silent chest. Spirometry and peak flow meter is required to detect variable expiratory airflow limitation. Obstructive pattern first detected by low FEV1 FVC ratio, and then you have to assess the reversibility, the increase of FEV1 by 12% and 200 ml with the use of bronchodilator means that there is reversibility. More the reversibility, more confidence will be in the diagnosis of asthma. If the reversibility is more than 400 ml, then probably you are dealing with asthma. Diurnal variation of peak expiratory flow of more than 10% is considered diagnostic. It should be assessed by twice daily peak expiratory flow measurement over 2 weeks and should be measured by same instrument. Spirometry may be normal and may not have reversibility in a single visit. That we should keep in our mind. Other ways are also there to assess variability. If you use anti-inflammatory agent, then after 4 weeks, if you assess the pulmonary function test, if the FEV1 reversed by 12% and 1200 ml, then there is variability. If there is fall in FEV1 with the exercise challenge of more than 10%, indicates variability. Excessive variation from one visit to another of FEV1 again indicates variability, variable expiratory airflow limitation. BPT or bronchoprovocation test may be done to assess the hypersensitivity of the airway. Then after you diagnose asthma from symptom and spirometry, we have to assess several other things. We have to assess the control of symptom, which is assessed by as per GINA from these questions. In the past 4 weeks, has the patient had any daytime asthma symptom more than twice per week, any night waking due to asthma, any reliever SAVA use for more than twice per week, any activity limitation due to asthma. If none of this present, then asthma is well controlled. If 1 or 2 present, partly controlled, 3 or 4 of them present, uncontrolled asthma. However, there is one caveat. If currently we are using ICS formoterol combination as a SOS basis in step 1 therapy in asthma? If it is so, then higher use of this ICS formoterol cannot be considered as indicator of poor control of asthma, because there the higher use of ICS is actually controlling the asthma inflammation. So in this case, it shouldn't be, this point is not valid. There are other tools, the questionnaire-based asthma control test, ACT, and asthma control questionnaire, the ACQ, can be used with less than 20 and more than 1.5 at the cutoff. You can see they are maybe used in clinical practice, however, mostly used in clinical trials. Not only symptom control, we need to assess the risk of exacerbation to assess the adequacy of therapy. If there is exacerbation of more than or equal to 1 in previous year requiring admission, or more than equal to 2 requiring OCS, or the lung function is low, less than 60%, that indicates that asthma therapy is not adequate. Even if the symptom control is okay, if these things are there, you consider that therapy is not adequate, you have to escalate the therapy. There are also other reversible factors that indicates poor risk of future exacerbation, like poor adherence, poor inner technique, smoking, eosinophilia associated with problem. This thing also needs to be addressed. Assess comorbidities like rhinitis, sinusitis are very common, present in more than 80% cases of asthma. GRD, obesity, OSC, suspect, always do polysomnography and use CPAP if required. Depression and anxiety, all these things needs to be assessed and addressed properly. Pharmacotherapy, mainly anti-inflammatory controllers are used. We have inhaled corticosteroid, mainstay therapy, budesonide, beclomethasone, fluticasone, can use LABA, long-acting beta agonist, salmeterol, formoterol, montelukast, aliquotrienes antagonist can be used. Sometimes sustained release theophylline. And the last resort is oral corticosteroid. For reliever, we use the short-acting agents, salbutamol, terbutaline, or maybe ipratropium. So ICS is the mainstay of therapy. For ICS, if we increase the dose from the moderate to high dose, it is seen the therapeutic effect plateaus and the side effect starts. So that's why before increasing the dose of ICS from moderate to high, always add other agents and also assess the modifiable risk factors before doing so. This is the dose range. For example, for budesonide, the low dose is 200 to 400 microgram, for medium is 400 to 800, and high dose is more than 800 microgram. This is the famous step care approach of asthma treatment. This is the current protocol as suggested by GINA in last 2020 guidelines. You can see if the person comes with very minimum symptom of less than twice a month, then start with step 1, means at this step you use low dose ICS formoterol on a SOS basis. Single isolated use of salbutamol is no longer recommended. Should always be combined with ICS. If you use SABA, then it should, whenever you use SABA, always take ICS along with, either with a single inhaler or with a separate inhaler. If the symptoms are mild, means twice a month, but less than daily, then start with step 2, where daily dose of inhaled corticosteroid or low dose is recommended. However, you can again use the same thing, means low dose ICS formoterol as a SOS basis in this step. It is seen is equally efficacious to control the symptom and to reduce exacerbation. So, for safety, GINA no longer recommends SABA-only treatment for step 1. RCTs are there, assess the budesonide formoterol in mild asthma or SOS basis, and it suggests that this SOS basis budesonide formoterol can reduce significantly the severe exacerbation versus SABA alone, and also versus maintenance ICS. So why this is so? Because if in mild asthma, if you use maintenance ICS, most of the time they are quite well. So most of the time they default. They do not use ICS, rather they start using the SOS SABA. And that leads to uncontrolled or exacerbation. So that problem is alleviated or controlled with this approach. It's a novel approach and will be the game changer in future. If the symptoms are moderate, means is present most of the days with history of waking due to asthma and with preserved lung function, then consider step 3 therapy, where low-dose ICS LAVA is used. If you use formoterol budesonide as ICS LAVA, then same ICS LAVA can be used as a maintenance and reliever therapy. If other ICS LAVA are used, then use SAVA as reliever. If there is significant symptom, nocturnal symptom, daily, more than daily symptom, with low lung function, then use medium dose ICS LAVA. Again, smart therapy means for formoterol budesonide, same inhaler can be used as maintenance and reliever. Can use some other add-ons like tiotropium leukotrienes. If still not control in this stage, go for step 5, where high-dose ICS LAVA is used. Or this is the actually severe asthma group, where you need to phenotype the asthma and use consider different biologicals, anti-Ig, anti-IL-5 as per the endotype. I will discuss this severe asthma group later on in detail. So whenever you start therapy, in each and every visit, you assess symptom, assess exacerbation rate, assess lung function, assess side effects, assess any modifiable risk factors like comorbidities and inhaler techniques, and correct them if required. After that, if the asthma is in control state for more than 3 months, they adjust the therapy, you step down. If not controlled, then you need to step up. For stepping down, you need to reduce ICS dose by 25 to 50% each and every visit. There are several non-pharmacological strategies like smoking cessation. Occupational exposure should be avoided, so proper occupational history or exposure of allergens should be taken. Avoid medication like beta blocker or NSAID or aspirin. They are responsible for symptom. However, they are not always responsible for symptom. As such, they are not containing in all patients. However, if the asthma is in uncontrolled state and they are taking these medicines, then always think of remediation of dampness or molds in home improves asthma control. So need to correct these things. Any cockroach or pest control with baits may be beneficial. Avoid indoor air pollution. Role of immunotherapy in GINA guideline, only SLIT has been, or the sublingual immunotherapy has been advocated in subsegment of asthma. If the asthma is there in step 3, step 4, an uncontrolled symptom, having allergic rhinitis with sensitization to only house dust mite, provided FEV1 is more than 70%. So only a small subset of asthma you can consider this SLIT. In moderate and severe asthma, consider influenza vaccination yearly. Bronchial thermoplasty is another approach, may be done in specialized center, although not validated that much, can be used in subset of severe asthma. So what is severe asthma? Here CTS guidelines suggests the asthma that requires treatment with high-dose inhaled corticosteroid plus a second controller medication and or systemic corticosteroid to prevent it from becoming uncontrolled or that remains uncontrolled despite this therapy. In other words, from GINA guideline, you can say, if this asthma is uncontrolled, even with maximal optimized step 4, step 5 therapy, this is known as severe asthma. To assess control of asthma, always consider not only for symptom control, consider the control of exacerbation also. So if you take 100 patients, you see 24% are there in GINA step 4, step 5. Among them, 17% will have difficult to treat asthma. Means they have GINA in step 4, step 5 with poor symptom control. However, most of them have correctable or reversible factors. Means often they have poor inhaler technique, poor adherence, other comorbidities. So those things needs to be corrected. Then again, reassess after 3 to 6 months, the leftover 3.7% where there is uncontrolled symptom. They are really severe asthma. So they are the GINA step 4, step 5, poor symptom control with good adherence and inhaler technique. So what should be our approach to diagnose severe asthma? First, detect whether there is difficult to treat asthma or not, means step 4, step 5 with uncontrolled symptom. Always reconfirm diagnosis of asthma. You may be dealing with something else. May have central tumor undetected. So always think of other possibilities. Then you correct inhaler techniques or ensure adherence. You modify your treatment, rhinosinusitis, GRD, OSC, anxiety, depression, etc. You address modifiable risk factors, any smoking, any known exposure to allergen, beta blocker, NSAIDs. Then review response after 3 to 6 months. If still uncontrolled, they are really severe asthma. Once you diagnose severe asthma, needs phenotyping or endotyping for proper treatment. So what is phenotype and endotype of asthma? The term asthma is now considered as umbrella diagnosis. It contains several entities with distinct mechanistic or pathobiological pathways. These are known as endotypes, so different pathways. Maybe also the asthma can be classified according to their clinical presentation, known as phenotypes, means early onset asthma, late onset asthma, atopic asthma, non-atopic asthma, steroid responsive asthma, steroid non-responsive asthma, all like that. There are several studies recently which actually clustered the asthma, the endotyping or phenotyping. And according to these trials, you can say currently that basically, currently we have two endotypes of asthma, T helper type 2 high and non-T helper type. In T helper type 2 high, there is atopic asthma or late onset eosinophilic asthma. The aspirin exacerbated asthma is also a subset of late onset asthma. In atopic asthma, it's well defined early onset, steroid sensitive, and late onset asthma, often steroid refractory, adult onset, and there is concomitant rhinosinusitis or nasal polyposis. In non-T helper type 2, most of them they are adult onset, mostly found in smokers, older persons, obese females, and they have quasi-granulocytic or neutrophilic influence. In T helper type 2, we detect by these biomarker of high skin prick test or IG, specific IG positive on one or more perennial allergen. Late onset, mainly high eosinophil counts or in sputum or in blood is used to detect late onset T helper type 2 asthma. High pheno may be useful also. In natural history, atopic asthma is most of the time treatable, there is preserved lung function. Late onset, whereas severe from onset, most of the time they have frequent exacerbation. And non-T helper type 2, they have variable course, often they are steroid resistant. Now, what are the biomarkers that we use? For T helper type 2, for detect atopy or allergic asthma, we need to see IG where there is more than 30 unit or not, and you need to prove by skin prick test or specific IG estimation of allergy to one or more aero allergen. That is essential. For eosinophilic asthma, we may detect the sputum eosinophil count. If it is more than 2%, is indicative. However, it is done only in specialized center. Blood eosinophilia, if it is more than 150 per microliter, or in a single visit, or more than 300 per microliter, if the records are there in last 12 months. So anytime if there is level is more than 300, then again it will be considered as eosinophilic type. High pheno of more than 20 parts per billion is a non-invasive method and fast, but it's not a very good indicator. Serum periostin can be used, but it's actually a research tool. For non-T helper type 2, there are limited biomarkers, interleukin 6, YKL40, and serum and sputum IL-17 can be used. So how to treat this severe asthma group? Nicely shown in European Respiratory Journal published in 2016, they have classified in 4 subtypes, 4 endotypes. Non-atopic eosinophilic 1, you can see this is the eosinophilic cutoff, 300, more than 300. There is non-atopic eosinophilic type, where there is no features of atopy as seen by skin prick test or specific IG estimation. However, they have high eosinophil. In this group, anti-IL-5, mepolizumab is the treatment of choice. Maybe other IL-5 anti-IL-5s are maybe used. There is another atopic asthma where there is low eosinophil. Eosinophil count is not high. However, they have high total IG and atopy as evidenced by skin prick test or estimation of specific IG to one or more perennial allergen. So this group, we use omalizumab or anti-IG therapy. There is significant number of patients, they have both of them, means combination of atopic and high eosinophilia. In them, both omalizumab and anti-IL-5 can be used. There is another subset, low T helper type 2, where both eosinophil counts are low and also there is no features of atopy. In them, we can use triotropium, use microlides, we can use even bronchial thermoplasty if facility permits. So these are the approach. Now, several newer molecules or biologicals are now available Pulmonolgy is the first one. It's a monoclonal antibody that targets the Fc portion of the free Ig and inhibits Ig binding to its receptor, preventing release of inflammatory mediators. Used in atopic subset, significantly improves asthma control stage 4. Also, mepolizumab is anti-IL-5, can be used if there is eosinophilic subtype. They are better choice if more the higher the eosinophil count, better the response. If the more exacerbation, it is the better choice. In adult onset asthma or nasal polyposis, it will be a good choice. The main thing that they do is they reduce exacerbation by significant number. Similarly, other anti-IL-5 like reslizumab or benralizumab, which is actually IL-5 receptor antagonists, they are also used in eosinophilic subtypes and they all reduce exacerbation rates. Dupilumab, it's anti-IL-4 receptor antagonist, also used in eosinophilic subtypes and improves in several parameters of asthma control. Another molecule is in development, tezepelumab, which is actually TSLP inhibitor. TSLP is a molecule on which there is the kind of more importance is currently being given. It's in the innate immunity pathway released from endothelium. They promotes the antigen presenting cell to help to develop T helper type 2 response. So that's why their inhibitor might be a good choice, however it's in phase 2 trial. So that's it. Probably in future, asthma is an inflammatory disease. We are currently treating with anti-inflammatory agents, but biologicals are coming out, and probably in future, the treatment of asthma will lie in the hand of proper use of these biologicals with proper endotyping of asthma with the use of correct biomarkers. Thank you.
এদিকে এখানে দাঁড়িয়ে কি হচ্ছে বুঝতে পারছি না। ভিডিও অপশনে ক্লিক করবো না, ক্লিক করার দরকার নেই, এমনি হবে। না না, রেকর্ডিং তো কিছুই বুঝি না। তুই আসিস কেন? জেনে আসবি, এটা রেকর্ডিং পার্ট। এবারে ইয়ে দেবি। কই হ্যালো, ওরা কোনো কাটেনি নাকি?
Sir, we can hear you.
Yes. So, Sally, are you here?
I am yes.
So, Sally, really proud of you. It has been such an excellent coverage
Thank you.
within such a brief span. So, actually, it was excellent. Again, I was not visible, so I repeat. I am really feeling proud with such an excellent presentation at this time. And now we will cover the second part, approach to COPD. That will be taken by Dr. Raja Dhar. He is the Director, Surgeon Training, National Allergy Asthma Bronchitis Institute, Kolkata, Consultant Pulmonologist, Fortis Hospital, Kolkata. He is a well-known name in the academic circle in India and abroad. So now it's over to Raja, approach to chronic obstructive pulmonary disease.
Backup team, please screen the video. Backup team, Dinesh, please start the session. Dinesh, are you there?
The question answer
Yes, sir.
session will be at the end.
Please screen.
Please start the,
Yes, sir.
the question, answer, and comments will be at the end.
Hi, friends. Good evening. I'm here today to talk to you about the other half of obstructive airways disease. You've just heard about asthma. You're now going to hear about COPD. COPD, as you would realize, is a vast subject. And I have picked up certain areas after discussion with Professor Ghoshal, which we will cover today. So we'll cover about natural history, smoking and COPD, in slightly greater detail about non-smoking COPD. I'll try and introduce the concept of COPD phenotypes and precision medicine. And then we'll speak about management, so the diagnosis briefly, various facets of management like dual bronchodilation and inhaled corticosteroids in COPD. I understand that the audience has a lot of postgraduate trainees. It has a lot of young pulmonologists, and hence we will try and keep this as basic and lecture style as is possible. I've got all of half an hour, so I'll go along slowly so that if you listen to this recording again, there are certain facets that you will pick up which would be useful for you in your exam. I start off with the gold definition of COPD. This definition had changed in 2019 and has remained more or less the same as before. And while this definition is easy, I want you to look at various parts of the definition, and I'll show you why the definition has changed the way it did in 2019. So you can see the first part, it says that it's a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation, which can be due to two factors, airway and or alveolar abnormalities. And this points to two different phenotypes, the airway phenotype and the alveolar phenotype. And we'll come back to this. And then the causative factor caused by exposure to noxious particles of gases and influenced by host factors, and the host factor is abnormal lung development. So let's look at each of these facets individually, look at the evidence behind this definition, and understand the disease a little bit better. So the first part, the easy part, is talking about persistent respiratory symptoms and airflow limitation that is due to airways and or alveolar abnormalities. So this is a cartoon, a pictorial representation of the pathophysiology of COPD that all of you would have seen. I hope you can see my cursor. In talking about COPD, that's a normal airway. And in the normal airway, the inner layer where I'm pointing to is the sticky mucus, the mucus lining within, and around that is the airway wall, the smooth muscles of the airway. Compare this normal airway to the airway in someone with chronic bronchitis. So chronic bronchitis causing obstruction, you can see the lumen narrowed, and the lumen is narrowed from two different factors. One is the increased amount of sticky mucus that lies there, what you see in yellow on there. And the second part is the inflamed and swollen airway. A combination of these two factors results in the narrowing of the airway. So the narrowing of the smooth muscles is the bronchoconstriction that we speak about in COPD, and the increased amount of mucus production narrowing the airway is the inflammation that we speak about in COPD. So that is the airway component that's alluded to in the definition of COPD. The other part is the alveolar part that gets eluded. So all of you, I don't need to talk about air exchange in the alveoli. in emphysema, the air exchange becomes difficult, expiration becomes difficult, and during expiration, there's air trapping, and hence, because of air trapping, there is hyperinflation. So that's the alveolar component, the emphysema component of the disease. So clearly, the definition of gold itself alludes to the alveolar disease component, which is the emphysema, and the chronic bronchitic component of the disease. This is from very recently. This is from 2017 in the ERJ Open, and it talks about the natural history of COPD. And let's look at this slowly over the next couple of minutes. So when we talk about natural history, there are certain factors which lead to the inception, the production, the birth of COPD. And if you manage to prevent these factors, that would be called primary prevention or primordial prevention. However, if these cannot be prevented, and we'll come back to what we mean by these, if these cannot be prevented, the disease should be detected as early as possible in an individual. So you understand the first part is trying to prevent the actual pathophysiology happening across the population. That's primordial prevention. Secondary prevention is more directed towards the individual, and hence screening and early detection form the spine of secondary prevention. Tertiary prevention is when the disease has happened, it's moved on, it's resulted in some degree of morbidity, and hence the spine of tertiary prevention is composed of treatment, rehabilitation, and other supportive measures about which we will not go into great detail today. So let's think about the primordial prevention. Primordial prevention happens in the general population. So think of the triggers of COPD, the smoking, the ambient outdoor air pollution, the exposure to biomass fuel, and we'll speak about these in greater detail later on, but trying to prevent this, promoting smoking cessation as a population-based strategy, trying to prevent use of biomass fuel and converting to LPG, for instance, is again a population-based strategy, and trying to reduce these results in reduction of risk of COPD in the entire population, and hence would be called primordial prevention. Next comes the primary prevention that is more directed towards individual. So you understand this is someone who is susceptible. So an adult male who smokes is susceptible to COPD, even though the disease has not happened, and focusing on the individual and trying to get that individual to stop smoking even before the disease is developed would tantamount to primary prevention in the susceptible host. And if you did that, so the first strategy reduces risk, the second strategy in the individual reduces disease incidence. The third part is secondary prevention. You have someone who has changes of COPD on spirometry, changes of COPD on a CT, for instance. So this individual who is asymptomatic, you try and reduce the prevalence and the consequences of the disease. You prevent the disease from moving forward. You prevent the onset of cough, breathlessness when the individual walks, exerts, and that would amount to secondary prevention. And this is after the first defect has been detected, after the diagnosis of COPD in the individual. And then common sense tertiary prevention is what we do most of the time. So by then the gun has fired, the bullet has left the gun. So that's when you're trying to control the disease, control morbidity and mortality. So symptomatic individuals, you're trying to reduce complications, reduce disability in the individual, and this is well after the onset of first symptoms. So I want you guys to remember all of this: primordial and primary prevention, secondary prevention, which is composed of screening and early detection, and tertiary prevention, which is based on treatment, rehabilitation, support. When you're answering your question, if you divide the management into these categories based on the natural history of COPD, the understanding of the treatment would be far better for the examiner who reads your answer or to whom you're speaking to. So if you think about tertiary prevention now, if you talk about tertiary disease, you've undergone exposure to risk factors. We talked about smoking, we talked about biomass fuel, we talked about outdoor air pollution. And this has resulted either in the airway disease, which is chronic bronchitis, or it's resulted in the emphysema. This results in impaired gas exchange. We talked about air trapping and hyperinflation when the emphysema component is predominant. The hyperinflation, the air trapping, the narrowing of the airways causes progressive breathlessness. This causes exercise limitation. There are exacerbations. Exacerbations result in poor health-related quality of life, decline of lung function, the respiratory failure, multiple admissions, and ultimately results in mortality. So we spoke about the various levels of prevention. This is the clinical progression. Once the disease has progressed, once the patient has become symptomatic, that starts off with primordial or primary prevention and goes on to mortality. Hence, if you think of a healthy individual with increasing age, there will be a decline of lung function, which is why when you're doing spirometry on an individual, recording the age and having a predicted FEV1 is so very important. And between the age of 25 to 75, you will have a 15 to 20% decline in lung function, which is related to the aging process rather than being related to a diseased lung or airway. Now think of someone with stable COPD where there are no exacerbations. And obviously, the decline in lung function between 25 to 75 would be far greater as depicted on this graph compared to when you see a patient who is an individual, not a patient, but an individual who is healthy, never smoker, not exposed to ambient air pollution, and not exposed to biomass fuel. The third category is the patient with exacerbations. So you see the decline that's punctuated by an exacerbation. I want you to look at the baseline here. So while there is gradual decline parallel to the blue line on there, as soon as there's an exacerbation, there's a large dip, but see how the lung function never comes back to the baseline again, and then starts declining from that point, have an exacerbation again, never goes back to the baseline again, and starts declining again. Which is why, while the treatment of stable COPD is important, the primary endpoint in your patient, all the trials that happens with drugs for COPD is prevention of exacerbations. It's exacerbations which kill patients with COPD. Hence, greater the decline in lung function, more rapid the progression, greater the burden of symptoms, more the exacerbations, and less the 5-year survival of these individuals. And it's a no-brainer to say that when you have an exacerbation, the amount of burden on the healthcare system of a country is immense, and hence exacerbations remain the primary criteria, the primary endpoint that you want to target when you try and find a treatment for COPD. So back to the definition again, and let me take the latter half of the definition. I'll come back to the central part later, but let's take the bottom bit, the end bit of the definition. So we said when we talked about causative factors, we talked about host factors and abnormal lung development. So let's see what GOLD means by abnormal lung development. And this is again a graph that I want you guys to remember for your exams. So the concept is that COPD can happen in two ways. The first is that you are exposed to the environmental factors, the smoking, the biomass, the outdoor air pollution that we spoke about, and hence over a period of time, your lung function declines at a more rapid rate as compared to individuals who've never been smoked and not been exposed to outdoor air pollution. So that's the dip in lung function, the rapid decline in lung function that you see in these individuals. So this is something that we have known for a long time, smoking being the trigger that we were taught. We know about other triggers that we have spoken about already. However, the second part, which is abnormal lung development, comes in with the yellow line on the graph on there. So these are individuals who are born with small lungs. So these people have a lesser lung development, smaller lung, and they start off with no COPD. However, over a period of time, these people have a decline in lung function, which is not very different to what normal people would have. However, in these individuals, because they've started off with a disadvantage, the disadvantage being smaller lungs, these individuals reach a lung function comparable to the previous group who have smoked, who've been exposed to outdoor air pollution by the time they are between 60 to 70. And hence the drop in lung function in these two groups is comparable. And hence both these mechanisms, the decline in lung function due to environmental factors and the smaller decline in lung function in those with smaller lungs, make you reach the same point between the age of 50 to 70. Hence, abnormal lung function in host factors is an important factor in the causation of COPD. We talked about exacerbations, and I think this downward spiral of COPD that a lot of you would have seen before is important. So you have a COPD exacerbation, results in a dip in lung function like we showed you. A dip in lung function makes you more breathless. More breathlessness means less physical activity. Less physical activity means being sat in a chair or being laid in a bed, probably with your inhalers, your nebulizer, etc. around you. Depression, social isolation, and hence fall in mental health, worsening quality of life. Worsening quality of life begets further COPD exacerbation. And with these multiple exacerbations, as you saw on the graph a little while ago, there's mortality at the end of the road. And hence, a reduction of exacerbation becomes the primary endpoint, and we'll speak about this more when we talk about the pharmacotherapy of COPD. So we have spoken about COPD being a heterogeneous disease in the definition itself. We have also talked about two phenotypes that are defined in the definition that Gold gives for COPD: the chronic bronchitic phenotype and the emphysema phenotype. So the chronic bronchitic phenotype has been defined for donkey's years. It's productive cough, 3 months per year, 2 or more consecutive years. That's the definition of bronchitis that we know for a long time now. And then you've got emphysema, which is confirmed on lung imaging. However, there are other phenotypes, the ACO phenotype, for instance, where there is persistent airflow obstruction. Some of the features are of asthma, some are of COPD, and you have typically someone like an asthmatic smoker who develops fixed airflow obstruction. Then there are frequent exacerbators, there are the rare exacerbators, which results in stable COPD. So these are accepted phenotypes of COPD. As we are going forward, we see other phenotypes of COPD. The pulmonary cachexia phenotype with the BMI of less than 21, the COPD bronchiectasis phenotype, which has been eponymously called the BCOS phenotype. So an HRCT shows bronchiectasis with a definite COPD diagnosis. The upper lobe predominant emphysema phenotype, where the treatment is different, where lung volume reduction surgery seems to work better. The fast decliner, so no exacerbations, but the decline is sharper in these people. The one with a profound amount of systemic comorbidities, so the one who gets a bypass early in the background of having COPD, for instance, the alpha-1 AT phenotype, and the non-smoking COPD, about which we'll speak in greater detail. So it's a heterogeneous disease, and these are the various phenotypes that we need to think about when we think about COPD. The last part of the definition, not the last part of the definition, it's the central part of the definition, but the one we have not discussed as yet, is about the causation by significant exposure to noxious particle of gases. So that's the part we have not discussed. So smoking is recognized as a causative factor for COPD. Professor Ghoshal has told me specifically not to talk at length about smoking and COPD. So I'll just stick to this one slide. This one slide which shows you that in patients who are smokers with COPD, if you quit smoking, and if you quit smoking at any point of time in the natural history of the disease, you will gain in lung function. So the decline in lung function will reduce irrespective of what point of time in your life you stop smoking. If you continue to smoke, which is the black line at the bottom there, the one I'm pointing out to, your decline in lung function will be faster. and you die quicker. So greater amount of morbidity, greater amount of mortality. It makes sense to quit smoking at any point of time in the disease process. You have less morbidity and lesser mortality. Let's now compare this with biomass exposure and smoking. I'll spend about 5 minutes speaking about this. So this is a study which comes out of Mexico from a while ago. And this talks about exposure to wood smoke and resulting in bronchial hyperresponsiveness. So this is the methacholine challenge test, which is a bronchial hyperresponsive, it's a bronchoprovocation test, which looks at bronchial hyperreactivity. And it compares two groups of patients. It compares patients who've been exposed to wood smoke and then patients who are exposed to tobacco smoke, hence the smokers that we talk about. And I want you to see this particular graph where the methacholine challenge test shows greater reactivity, greater airway hyperreactivity to wood smoke as compared to what you do with tobacco smoke. So the airways of wood smokers are greater than the airway hyperreactivity of conventional tobacco smoking. What about systemic inflammation? So biomass exposure is greater in women. This was a study which was done out of the city where I am from, so city of Kolkata, which looked at various inflammatory markers like C-reactive protein, interleukin 8, and it compared the levels of these acute phase reactants in wood smoking population, so biomass exposure population, and the cigarette smoking population. And you can see across the board, the pro-inflammatory cytokines were greater in amount in the biomass exposure group as compared to the tobacco smoking group. So greater burden of systemic inflammation in patients who are exposed to biomass smoke as compared to patients who are cigarette smokers. If you look at the CT scan of the tobacco smoking population versus the biomass population, and this is going back to another Mexican paper where most of these studies seem to come from, you can see that in tobacco smoking COPD, there is greater amount of emphysema. I don't know whether this shows up well on the slide that you see in front of you or not. However, what you see in the biomass smoke is mosaic pattern, which is consistent with small airways disease. So in the three slides that you've seen three different things. First, airway hyperreactivity is greater in the biomass exposure group as compared to the tobacco smoking group. Second, you've seen that the acute phase reactants, the inflammatory markers, are greater in the biomass exposure group as compared to the tobacco smoking group. And third, the lung component, the emphysema component is greater in the tobacco smoking group, and the airway component, the chronic bronchitic component, is greater in the biomass group as compared to the tobacco smoking group. And this shows more of the same. This is a study which is very recent from respiratory research. And this shows you that in patients who are smokers, the component of airways is still there, more than 50%, but in wood smoking population, in the biomass exposure population, the airway component is far greater as compared to what it is in smokers. And this bar diagram again shows you more of the same. This is patients who are exposed to cigarettes. So smokers COPD, you can see, is much greater with the emphysema component, much less of airway component. Whereas when you look at people who are exposed to wood smoke, the airway component is far greater as compared to the lung component. And carry home message, non-smokers COPD have less emphysema and more small airway obstruction. I'll skip that and go into the next part in the last 10 minutes of my talk, which talks about precision medicine and phenotyping. So precision medicine is an approach that takes into account individual patient variability. It's targeting individuals, trying to find out their individual characteristics, which is defined by the gene, the interaction with the environment, and the interaction with the lifestyle. And I feel, and a lot of others feel, that precision medicine is the future of COPD care and also the other respiratory diseases that we see. So the first step in trying to phenotype individuals in practicing precision medicine is talking about biomarkers. So biomarkers help in three different aspects. It helps to identify subgroups of patients who would most likely benefit from a therapeutic intervention. So let's give you an example. So whether an individual will respond to inhaled corticosteroids in COPD would be defined by the blood eosinophil count. So that is identifying subgroups of patients who are most likely to benefit. Would patients with a low eosinophil count come to harm by an inhaled corticosteroid? Yes. They can get pneumonia if they have a low eosinophil by the asthma component, by looking at IgE, by looking at an eosinophil count, and then administer drugs, maybe a biologic, for instance, and there are trials of biologics in COPD, that's predicting therapeutic response to a drug at an individual level. And then segregating patients who are at risk of poor outcomes. So this is COPD, but think about COVID. So you have patients who have a raised D dimer, your patient who has a raised neutrophil lymphocyte ratio. So a lower neutrophil lymphocyte ratio are individuals who are at greater risk of mortality. So that's predicting poor outcomes from biomarkers, and that's what these individuals' biomarkers do. So when we talk about COPD, the symptoms, so the shortness of breath, cough, and sputum, there are risk factors that we've spoken about. So the tobacco, your occupation, ambient air pollution, biomass, etc. And marrying the symptoms and the risk factors together, you guess this individual might have COPD, you get a spirometry done, and the spirometry tells you whether your diagnosis is correct or not. So key factors, key indicators for considering the diagnosis of COPD is the presence of dyspnea and its progression gradually over time, worse with exertion and being persistent. The cough being intermittent, mainly unproductive with recurrent wheeze. Sputum production, which indicates more of a chronic bronchitic phenotype. The recurrent lower respiratory tract infection, the risk factors we've talked about, the tobacco smoke, the smoke from wood smoke, coal smoke, etc., occupational dust, etc., are risk factors for COPD. And the family history, low birth weight, childhood infections, etc., which result in lower, lesser lung development, all are host factors for COPD. So all of these factors together, you integrate them, and together you reach a diagnosis of COPD. And that's a volume time graph. You can have a flow volume graph too, but you can see a normal tracing and the tracing of an obstructive disease. The ratio is there for you to see. So a ratio of less than 0.7 tells you obstructive disease, and then lack of reversibility and obstructive pattern tells you that you have COPD. And this is the gold tool. Again, this is grown, this is changed over a period of time. As of today, a spirometry tells you that this patient is obstructive airways disease with a ratio of less than 0.7. And then the grade of gold, 1, 2, 3, and 4, depending on the FEV1, tells you how severe the spirometry is in a patient with COPD. So mild, moderate, severe, and very severe. So you can see that the spirometry has actually been taken out of the gold grid. The gold grid itself, the A, B, C, and D, is now dependent on symptoms, which is dependent on the CAT score, the COPD assessment test score, or the MMRC, the Modified Medical Research Council score, which gives you the load of symptoms. And then the second part that you see on there is the number of exacerbations. So whether a patient has 2 or more exacerbations requiring treatment with steroids and antibiotics, or whether the patient has had an exacerbation which is severe enough to lead to a hospitalization. So those give you the symptom burden in these individuals. There's a long list of differential diagnosis on there. So you see the list of differential diagnosis for COPD. There's asthma, there's heart failure, there's bronchiectasis, TB, etc., which in itself can result in obstructive airways disease, the obliterative bronchiolitis, etc. And you need to think of these before you categorize these patients into the COPD basket. We'll give you these slides to go through in greater detail, but important to remember that there are mimics of COPD, differential diagnosis of COPD. That's worth remembering. Now we come to the last part, which is the management of stable COPD. So the management of stable COPD has also evolved like everything else, and we know that now the management is mainly bronchodilators. So you see across the group, whether it's group A, B, C, or D, it's actually a bronchodilator which is central to the management of COPD. However, in the exacerbation-prone population, and we mentioned eosinophil counts a little while ago, you can see even on the GOLD chart talks about eosinophil count of more than 300, and ICS can be added in this small category of patients who have exacerbation-prone COPD, and we'll come back to this in a minute. So bronchodilators form the backbone of management across all groups of stable COPD. In COPD, GOLD has asked you to review the patient and look at symptoms and diagnose and look at propensity for exacerbations. You assess the patient in looking at inhaler technique, adherence to medications, non-pharmacological measures like pulmonary rehabilitation, vaccination, smoking cessation, etc. And based on these, you adjust treatment accordingly. So review, assess, and adjust. This is similar to what Gina gives you for asthma, and it's important to remember these steps when you see your patients. So the pharmacological treatment is based on control of dyspnea, so management of symptoms, and management of exacerbations. So left is management of dyspnea, and you can see the main important treatment here is a bronchodilator or a combination of bronchodilators, either a LAMA or a LABA or a combination of a LAMA plus a LABA. The ICS comes in certain sections of the population, and we'll talk about that in a minute. You can switch inhaler device or molecules if you so wish, and that's your management of dyspnea. When you talk about exacerbations, again, you start off with a LAMA or a LABA. Depending on certain factors, you can either you can add in an ICS or you can add in a LABA to a LAMA. This depends on exacerbations and depends on the eosinophil count. In some patients, as the disease progresses, you can have a triple, so a LAMA plus a LABA plus an ICS. And then there are other exacerbation reducing strategies like low-dose macrolides, the anti-inflammatory treatment, roflumilast, especially in the chronic bronchitis category of patients, and something not mentioned on the slide, N-acetylcysteine, which also seems to work in certain sections of the population. So this is what GOLD says about bronchodilators in COPD. The fact that bronchodilators are central to symptom management and given on a regular basis, it reduces symptoms and it might prevent progression of symptoms. As required, SABA or SAMA helps improve symptoms and might improve FEV1 to an extent. A combination of a SABA or SAMA is better than individual drugs. A LABA and a LAMA improves lung function, dyspnea, health status, and reduces exacerbations. LAMAs have greater effect on exacerbation reduction compared with a LABA. Combination of a LABA and a LAMA increases FEV1. A combination treatment with LABA-LAMA reduces exacerbations compared to monotherapy. TIO improves efficacy of pulmonary rehabilitation and increases exercise performance. Theophylline, which we use very often without reason, it exerts a small bronchodilator effect in stable COPD and has modest symptomatic benefit. So GOLD recognizes that theophylline helps in certain individuals. And I want all of you to remember this. This is even present on the GOLD website. Look at these as being the evidence-based interventions in management with bronchodilators in COPD. The fact that a LABA-LAMA is better than the short-acting counterparts, the SABA and the SAMA. Immediate relief of symptoms might happen with a SABA or a SAMA, but long-term benefits are sustained with the LABA-LAMA combination. If you've started with one bronchodilator, add the other one in. That helps in persistent dyspnea. Inhaled bronchodilators are much more better than oral bronchodilators, even from a safety perspective. And theophylline is still not recommended unless you use it as an add-on treatment or other treatments are unavailable. This is a slide which drives home the factor that a LABA and a LAMA have synergistic effect it has add-on effect in patients with COPD. This shows the synergism even greater. So the slide, what it says on there is important. Administration of LAMA does not modulate the intracellular synthesis of cyclic AMP. However, a LAMA in combination with a LABA will increase the synthesis of cyclic AMP. This is the systematic review and a meta-analysis of dual bronchodilation. This is what is called a forest plot. And you can see that the forest plot shows that all the studies favor a combination as compared to monocomponents, be that in the improvement of symptoms based on SGRQ score, transitional dyspnea index, or be that based on FEV1, and you have a similar chart for exacerbations. This is one example out of many combinations, glycopyrronium and formoterol, greater improvement in pre-dose trough FEV1 versus monotherapy, and the tiotropium effect lasts for 12 hours, lasts with a 12-hour dosing interval. Hence, glycopyrronium formoterol is clinically beneficial in symptomatic patients. This is not just true of glycopyrronium formoterol, it's an example. The example holds true to a lesser extent even in other combinations of a LABA and a LAMA. This is FLAME. This compares a LABA and an ICS. So salmeterol fluticasone versus indacaterol glycopyrronium, and it showed for the first time that even exacerbations are reduced more with a LABA and a LAMA as compared to a LABA plus an ICS. And this reduction is the greatest in moderate to severe disease as compared to what happens in very severe disease or in mild disease. So moderate to severe disease, greatest benefit with the LABA-LAMA as compared to a LABA and an ICS. This is key points for use of inhaled corticosteroids or even roflumilast, so anti-inflammatory treatment. So long-term monotherapy with ICS, not recommended. Coming down on the dose is something which is warranted. Long-term treatment with ICS increases the chances of a pneumonia. Oral corticosteroids are not recommended in patients with COPD on the long term. In patients with severe or very severe airflow limitation, a PDO4 inhibitor, which we've spoken about before, roflumilast, can be helpful. Other add-on treatment like low-dose macrolides can be useful as add-on treatment in gold DCOPD. Statins are not recommended. Mucolytics, so like NAC, are recommended in a small selected segment of patients. This is about inhaled corticosteroids. So inhaled corticosteroid with the LABA is more effective than the individual LABA and the ICS. Regular treatment with ICS, as we said, increases the chances of a pneumonia, especially in patients with severe disease. And the triple often improves lung function, health status, reduces exacerbations as compared to monotherapy. So the triple is definitely better than single drugs, which again is more or less common sense. And oral glucocorticoids are a no-no because of the numerous side effects that these drugs have. This is from Gold, and I think this is very useful. So when you think about using the inhaled corticosteroid, think of this chart. So strongly support the use of inhaled corticosteroid in patients who have exacerbations which warrant hospitalization. 2 or more moderate exacerbations in a year, a blood eosinophil count of more than 300, and especially if you have the ACO category, asthma COPD overlap category, it's very useful. Recommends against using when there are repeated pneumonia events, when the blood eosinophil counts are low, and if you have a previous history of TB, it recommends against use. And I want you to remember this when you think about the prescription of steroids in patients with COPD. What about withdrawing inhaled corticosteroids? And again, in patients without frequent exacerbation, think of stopping the inhaled corticosteroid at one go. Even in patients who have exacerbations, we recommend that you reduce the dose of inhaled corticosteroid in a stepwise fashion, monitor the eosinophils. In patients with eosinophils of more than 300, you would not want to withdraw or reduce the dose of the inhaled corticosteroids. However, in stable patients with a eosinophil count of less than 300, you would want to reduce and stop the inhaled corticosteroid at some point, especially in gold DCOPD. Triple therapy, so these are 2 definite trials with triple therapy, the impact and the ethos. and both of them together say what's there in the red box down below. So beneficial effect of fixed triple drug therapy versus fixed dose LAMA-LAMA combination, and reduction of mortality in symptomatic patients with a history of frequent and or severe exacerbations who were previously receiving maintenance therapy with triple therapy, LABA-ICS, or dual long-acting bronchodilators. So the triple does work well in certain segments of the population, especially in GOLD COPD. We spoke about mucoregulators, the fact that it helps to improve health status in certain patients with multiple exacerbations who are of the chronic bronchitic phenotype. And it's important add-on treatment in that segment of the population. We've This is important. The non-pharmacological treatment is not something we are speaking about today, but smoking cessation is important. We have talked about pulmonary rehabilitation briefly. These are the various facets of smoking cessation which are important. Vaccination with the 23-valent vaccine, and so the 23-valent pneumonia vaccine and the 13-valent vaccine is important, and so is influenza vaccination, and the treatment of comorbidities is also important in COPD. I was going to speak about COVID and COPD, but we'll do that another day. I have probably taken up more time than was what was due to me, but I hope if you listen to this talk and listen to it again, it should help you in the long term in managing your patients with COPD, and more importantly, in answering questions on these facets about COPD.
Backup team.
Ghoshal sir, your video, please.
Professor Ghoshal, you need to open your video.
Hello, everybody.
Yes, sir. You are audible, sir.
No, I know I am audible. Whether they are a bit tired after covering all this. Okay. So Raja, as usual, this was very good and probably a bit long. And again, excusable, seeing the first topic. Now those who have joined late or who have been a little inattentive in between. So we have covered the two extremes, asthma and COPD, in the vast spectrum of obstructive airway diseases. And again, there are innumerable permutation combinations in real life. And actually, there is no clear-cut differentiation even all the time. And frequently, there are overlap. So our basic focus was to stress on that both are airway narrowing, but it is episodic airway narrowing in asthma, persistent progressive airway narrowing in COPD. And we know now in asthma, the treatment is basically anti-inflammatory, that is inhaled corticosteroids, only SOS bronchodilator. But in COPD, we still do not know the ideal anti-inflammatory. So basically, we are dealing with bronchodilators, maximum bronchodilators, and dual bronchodilators. The most important thing that Celia has told is the recent change in GINA guideline. Actually, it was there in the pipeline for quite a few years. In the very mild cases, do you give only SABA? The present answer is no. You always give ICS with bronchodilator. That means it has to be ICS containing regime. And the best thing would be formoterol because of early onset of action. So ICS formoterol combination has been given the go in mild cases. SOS use of ICS with short-acting LABA. And Sally has also covered the severe asthma very nicely. And for severe asthma, naturally, you have to go for the phenotypes, that is the external appearance, the presenting appearance, and phenotypes, that means the biomechanistic mechanisms. Practically, this is also precision medicine. So precision medicine is now a term for all the science spectrum of medical science, as in COPD, so in asthma. And Raja has covered a vast topic, and I am happy to note that this is Novi classroom because you get flavor of both the worlds, the standard medical college classroom and the standard corporate presentation. So a very good combination. And also Raja has covered non-smoking COPD, talk of the day, because this is still vastly under-recognized and under-diagnosed. And for COPD, the latest change from 2018 was that first you do the spirometry, you grade them according to severity, then you take up the spirometry out, then you group them according to the symptoms and history of exacerbations. So first graded, then grouped in COPD. So now we'll go to the interactions. One question was there, I think it is for Sally. What is the duration of as needed low dose ICS formoterol to be taken in step 1 and 2 GINA guidelines? That means how long it may continue, 1 day, 1 week, or 2 weeks? That is the question exactly.
As such, there is no duration, because these group of patients, they have mild symptoms and may need to continue this approach lifelong. Rather. So whenever they have symptoms, they rather than taking only SABA, means salbutamol or terbutaline, whatever, they should take this combination of LABA along with ICS on a SOS basis, so that they have at least some amount of controller or anti-inflammatory agents, so that asthma doesn't exacerbate. So that's the approach. Do not have any duration.
Raja, any comment on this?
So I think the Sigma 1 trial showed that in patients who are on an ICS and a LABA on formoterol and budesonide, while the exacerbation in two groups, the group using SOS medication versus the group using maintenance medication, the reduction of exacerbation was equal. However, the preservation of lung function, FEV1, was slightly lower in the group using SOS medication as compared to using maintenance. So I think that's the rationale of what Shelley said. While SOS medication is going to reduce exacerbations to an extent, however, using maintenance medication is almost compulsory even today, rather than using just SOS medication as and when required. So I think maintenance plus SOS is the order of the day, rather than as and when required only.
No, that's for step 3 and step 4.
Sally,
Only
okay.
mild.
We take it, Sally. Okay. So practically, we all agree this was initially a compromise because this is human nature. This adherence to inhaled corticosteroids is really low in real life. So whenever you take, don't take only SABA because that may be dangerous, because the inflammation part is being uncontrolled, only masked by taking SABA. So they have come to this compromise that whenever you take this combination. So the inflammation part will be taken care of. And how long? That means if the patient is okay with this, again, 3 aspects: the symptoms, the day-to-day activity, the recreational activity. Is he okay with this? Then he may continue it indefinitely, no particular day or week. So again, ultimately it's a compromise, knowing fully well that ICS is the mainstay of therapy in asthma.
So I think the other thing, sir, is about step down. So I think the question also alludes to step down. So I think step down is only when you've actually maintained perfect control for at least 3 months and you can step down a stage, but not before that. I think that's also one of the points that the question was making.
Yes, but again, this SOS formoterol ICS has been given on that aspect also, that probably patients are not very aware of their control. They may miss even. So it is better to give the ICS at least. So whenever they take this symptomatic SAVA, they take the ICS as well. And formoterol, because of its earlier onset of action. Okay. And then there was another question. Vaccination protocol for asthma. First Sally and then vaccination protocol for COPD for Raja. Yes, Sally first.
In asthma, the vaccination which is effective is influenza. Pneumococcal vaccine is not routinely to be used, but for more than 65, definitely it should be used as per the guideline and each and every person. For influenza vaccination, mainly for all, if asthma is more than mild, means moderate or severe, then definitely influenza vaccination for every year should be used in asthma.
Raja, COPD, vaccination protocol.
So I think it's COPD is far easier. The evidence is far more robust as compared to what it is for influenza. So for COPD, influenza vaccination needs to be done on a yearly basis for all adults who are proven to have the disease. The time for vaccination would be just after the monsoon season. It's variable across the country, but it's easy to remember August, September, rather than trying to remember which part of the year for various parts of the country. For pneumonia vaccination, you would start off by giving the 13-valent vaccine, which is the Prevnar 13 vaccine. And this is followed by at least 8 weeks or maximum of 1 year, you administer the 23-valent vaccine, which is the Pneumovax 23 vaccine. So Prevnar 13, 8 weeks interval at the minimum, 1 year interval maximum, you then administered the Pneumovax 23 vaccine in these individuals.
So the concept is that COPD is a much more deadly disease and it's a systemic disease. Actually, asthma was not there, say even a couple of years back. So for COPD, it is both pneumococcal and influenza. For asthma, again, if it's a severe asthma, you can think of pneumococcal as well, but influenza is there in all the list. Okay, both of you have talked about eosinophils. Sally has talked about for his making the phenotypes, and Raja has talked about using ICS in COPD. So, Sally, what eosinophil look for? Blood eosinophil, the percentage, the absolute eosinophil count, exactly what?
Now, for blood eosinophil, the absolute count is to be seen. More than 300 is considered to be a good indicator for assessing eosinophilic inflammation. However, 150 is also taken up because in clinical practice, it was seen that the use of mepolizumab, the effectivity is seen if eosinophil count in a single visit is more than 150. Other than that, if you see percentage, percentage of sputum eosinophil that we take, more than 2% of sputum eosinophil is considered as indicator of eosinophilic inflammation in the air. So that's it. For blood, it is absolute. For sputum, it is percentage.
Okay, the question is a little tricky. How to convert eosinophil count that you get as percentage? Actually, you don't convert. Absolute eosinophil count is something to be counted. You don't see the total count and it is 2%, so you convert it. That is not the rule. You have to get it counted.
Better to have count.
You have to. When you are talking of absolute eosinophil count, you have to count. You cannot go by percentage of 2% of 10,000. That means something. Okay, Raja. So will you depend on eosinophil only for considering ICS in COPD?
You wouldn't, sir. So I don't think you would. I mean, even with asthma, as Shelley pointed out, I don't think you would just depend on eosinophils. So you would depend on the clinical severity of the disease. You would depend on the number of exacerbations the patient is having, including admissions which are required due to an exacerbation. And then you would depend on the eosinophil count. It's interesting. I mean, for the audience, it's interesting to note that in COPD, it's actually a low eosinophil count, which is more significant than a high eosinophil count. So the studies are more robust in showing that if you have an absolute eosinophil count of less than 100, your chance of causing a pneumonia with an inhaled corticosteroid is actually greater than the benefit you accrue by giving an inhaled corticosteroid to a patient who's got a eosinophil count of more than 300, an absolute eosinophil count of more than 300. So here, both a high and a low eosinophil count are significant when you're thinking about prescribing or not prescribing an inhaled corticosteroid in your patients with COPD.
Okay. So we have covered the two extremes. I'll go to both of you. First Sally, then Raja, and very briefly. Sally, exactly what is asthma COPD overlap? Do you believe in it or not?
Actually, asthma is a clinical diagnosis, and COPD clinical plus pyrometric diagnosis means FEV1 FBC should have shown a fixed airway obstruction. Now, problem is that often we see in our clinical practice that yes, there is clinical subtype clinical features of asthma, but still there is some fixed airflow limitation, and some features are indicative of COPD. Reverse is also there, primarily looking like COPD, some asthma-like phenotypic features like maybe childhood onset features, symptoms, may have nocturnal symptoms, a history of some allergy, other allergies, often are associated. So in this group, when symptoms or features of both the disease are there, it is very difficult to differentiate these two. And most of the clinical trials actually have included either pure asthma group or pure COPD group. In between this group were not included. So that's why the necessity of keeping the asthma COPD group so that we can include this group in clinical trials and see how the treatments works in them.
Raja, anything further?
So I think the dispute is, sir, about whether there's a condition called ACOS or not, whether there is an asthma COPD overlap syndrome or not. There is no dispute about whether there is asthma COPD overlap or not. We have learned from our childhood that asthmatics who smoke, chronic asthma, etc., will lead to fixed airflow obstruction at some point of time, and that entity has existed from your training days and our training days, and the juniors now also learn about the overlap. The dispute is, do you have a condition where patients have at inception asthma COPD overlap, and whether that's a separate syndrome or not? And we believe today, and this might change tomorrow, but as of today, we don't think there's a syndrome as such. Over a period of time, can develop fixed airflow obstruction and develops ACO. Similarly, like Shelly said, you can have a category of COPD patients which have a eosinophilic airway and have hyperreactive airways, which you treat as ACO.
So practically, this is to stress to the audience that asthma is a very common disease. Prevalence is high. COPD is also prevalence is high, particularly in smokers and in the adults. So it is quite possible both two have come together. That is known as the delta. So asthma COPD overlap is a common combination that may happen in the population. This is number one. Number two, asthma is essentially diagnosed clinically by history and additional things. COPD is essentially diagnosed by spirometry, post-bronchodilator FEV1 less than 70% and the others. So when you get combination of the two, and of this the clinical judgment gets the upper hand, the symptomatic part and the long history, then you diagnose as asthma COPD overlap. But still the notion is that basically the airway inflammation is different. So asthma airway inflammation is different from that of COPD airway inflammation, but fixed airflow obstruction can develop in any untreated, underdiagnosed, undertreated patient of asthma, and that may masquerade as COPD in the long run. The differentiation is important because for asthma, when I am sure that this is predominant asthma, actually we have to write long before asthma with COPD or COPD with asthma. It is predominant asthma, anti-inflammatory inhaled corticosteroids. If you think of COPD, you go for bronchodilators and then naturally dual bronchodilators. In the same tune, Shelly, where do you keep LAMA in treatment of asthma?
LAMA, there is role definitely in advanced stages, means if you're treating asthma in step 4 of GINA or maybe step 5, it can be used as an add-on. So if symptoms are not controlled, even with use of moderate or high dose of steroid, or plus minus other controllers, then this tiotropium can be used. There is evidence on this tiotropium. I do not have any whether there is any evidence on other anticholinergics or not, but there is definite evidence on tiotropium that in the severe group for symptomatic control, it can be added. It can be an add-on therapy with the ICS, moderate or high dose ICS LAVA, along with plus minus other controller therapy. So that's
exactly add-on therapy. I'll go to Raja this question. During this COVID situation, what do you do for spirometry or other things you do for? But before that, about this spirometry, in no case of asthma, COPD or asthma COPD overlap, it should be diagnosed on a single spirometry. It is always more than one, at least two, in different point of time. For asthma COPD overlap, it is, let's say, within 2 years, there has to be two different. Practically, when you get two different spirometries at a say length of say 6 months or 1 year apart, you really understand the true picture. So more than one spirometry, unless it is very severe obstruction and there is no element of asthma, you can go for single spirometry, but that too is not advocated. But Raja, during this COVID situation, spirometry and what?
So can I add something to what Shelly said with your permission about sort of
course, yes.
asthma, sir? So, you know, we talked about precision medicine. Shelly talked about precision medicine. I talked about precision medicine. So there is now a category of patients who seem to respond better to tiotropium in asthma. So it's people who have a BMI of less than 20 or a BMI of more than 30. So outside the normal range of BMI, who are smokers and who have hyperreactive airways, who seem to respond best to tiotropium. That's not to say it shouldn't be prescribed in others and as sort of add-on treatment, but it seems to be this phenotype which responds best to tiotropium. And that was just something I wanted to add to what Shelly said.
But still, Raja, still the general perception still is of the add-on therapy, isn't it?
Sure.
Because
so add-on, but add-on in this particular group is what I'm saying. So, you know, so add-on in everyone, but more so
exactly.
in this category of patients as compared to others.
Do you do spirometry, and if not, you do what?
Yeah, so I think you depend on symptoms. So unfortunately,
spirometry at COVID times.
Yeah, so unfortunately, we know that spirometry is the most aerosol generating procedure we do in all of respiratory medicine. And it is a risk for healthcare workers, patient relatives, patients who are sat in the same room. And hence, you try and avoid spirometry, especially when there is a suspicion that someone might be affected by COVID infection. We know now that there's a large load of asymptomatic patients in the community. We know that there's community spread of COVID today. So essentially everyone is suspect of COVID unless proven otherwise. So spirometry should be avoided till you think that it's absolutely necessary. If you think it's absolutely necessary, then adequate precautions during spirometry should be taken, which is making sure that you're wearing the N95 mask, there's no one else in the room, you try and maintain some distance from the patient if that's possible, and you do all prescribed hand sanitization measures. If spirometry can be avoided, you avoid it and you diagnose the disease based on symptoms. There are various scoring systems, etc., which are available both for asthma and COPD. Shelley has very appropriately said that asthma is a clinical diagnosis anyway. So for asthma, spirometry is non-essential in most cases. Even in COPD, a good history can get you to diagnosis in lots of cases. And during the pandemic, it is better to avoid a spirometry unless you're absolutely sure that the patient is infection-free, which is rare.
Okay. Now, there are some other voices on this. Number one, some groups in India itself are doing spirometry post-COVID after 6 weeks. They say the patient is no more infective. Some centers are doing spirometry, but still spirometry is a very much aerosol generating procedure. So,
sir, that is, sorry, sir, that's different though. I mean, I agree with that group and we do it. I mean, you and I do it. I'm sure Shelly does it too in people who are post-COVID.
Yes.
Doing spirometry in someone who's post-COVID actually ensures that the patient is infection-free. I was talking more about people who've never had the infection.
I understand. General population.
Yeah, general population.
I am not sure.
Yeah.
Number two is probably impulse oscillometry where available is a less aerosol generating procedure. And if I have my hand there, A good high resolution CT chest with expiratory view gives a very good perception about the airway obstruction, particularly the small airway obstruction. But still, asthma is basically what we treat is a symptom-driven management. So spirometry is not that needed every time. And for COPD also, it is first graded. So spirometry is then out. Then it is grouped according to the symptom and exacerbation. Again, you need not do spirometry every time. So try to avoid spirometry in those cases where we are not sure, or again, you can go for the clinical part and the questionnaire, asthma questionnaire, the COPD assessment test, and other things. Okay.
Just to say, we've got a young audience, sir. So it's not to say Professor Ghoshal is advocating CT scan for the diagnosis of COPD.
No, I am not.
Say that CT scan is something that you can do as an add-on measure in a small section of patients.
I am advocating that when you are getting a CT, extract as much as possible from that plates.
Right.
That's what I am advocating. So, and again, when you are writing for HRCT, in any case where I suspect of even post-COVID, please go for with an expiratory view. So HRCT chest with expiratory view. That is what is I am advocating. Okay. So what is the meeting point there? We have discussed asthma, we have discussed COPD, asthma, COPD overlap. Raja, a very brief comment about bronchiectasis, how much airway obstruction, and then Sally about tuberculosis and TOPD. First, Raja, bronchiectasis.
So bronchiectasis overlap, what I call the BCOS syndrome, and even asthma bronchiectasis overlap, even without ABPA and with ABPA, I think are found in about 30% of cases. So there's a 30% overlap of bronchiectasis with asthma or COPD. And one of the reasons you would actually get a CT scan done in patients with asthma or COPD is when you're suspecting someone has got background bronchiectasis, multiple exacerbations, patient producing a lot of phlegm, patients growing pseudomonas, for instance. In all these categories of patients, you have to think that there might be background bronchiectasis along with the airways disease, be it asthma or COPD. And if you find asthma and COPD together, it's your responsibility to look for ABPA. I think that's an important message that should go out from us.
Slide. Okay, Shelly, TOPD, what is it?
Tuberculosis, it was first recognized from few African studies that tuberculosis really produce same COPD-like pictures or COPD-like ear obstruction. And this holds true also in India. We have a profound number of tuberculosis cases. In post-tubercular cases, there is some airway narrowing. Some also there is loss of lung parenchyma, and all this leads to same airflow narrowing that we see in COPD cases. So tuberculosis for post-tuberculosis fibrosis is a cause of COPD that we can say right now. And mode of treatment is mainly, again, will be the bronchodilators that we use in COPD cases.
Okay, so we have come not a very long way, moderate way actually, covering the spectrum of obstructive airway diseases. And I think both our speakers have done an excellent job, both of them. And again, the recordings will be available to the registered delegates. So you can go through this again. And we are targeting it the last Friday of every month, but again, accepting very significant holidays. So 25th December will be again a Friday. So we will be doing it on 18th December. And the next Novi Pulmonology MasterClass is on approach to diffuse parenchymal lung diseases. We'll have with us again, same protocol, Hongsuman Mukhopadhyay and Devabani Vishwas. Again, I remind you, Novi, this is classroom concept. This is not a webinar in its usual style. We are dealing with the basic concept, the clinical correlation and relevance, and clearing the confusion. Anybody, any question or any comment? Raja,
Sir, I would like to put my submission before you to the entire Nobi team. First of all, thanks to Nobi and to Professor Ghoshal in particular for this excellent initiative of the masterclass. my sincere thanks to two stalwart speakers, Rajadhar and Dr. Shaili Shamim. It's a mesmerizing session from both of them, as usually. And rightly said by you, Professor Ghoshal, that it is disseminating, not only disseminating knowledge to the young promising chest specialists, but giving a flavor of classroom in particular, which is very, very different from the usual webinars which are happening across nowadays. So, and I'm very glad to share with you that we are reaching almost to 500 plus young chest specialists, sir. So I was traveling across, last 15 days from different places. Like I was there in Kerala, where also I found a lot of excitement, among the young chest specialists about this class. So we are on the right track, sir. And thanks once again to the entire NABI team for this unique initiative. And I'm sure we from Lupin Respira feels privileged to be a part of such initiatives. And in future also, we'll be continuing this such initiative. Rather, we'll be part of this initiative. So
I thank Raja, Sally, and the entire Lupin team.
Raja, can I announce something very quickly?
Yes,
so
Raja.
You mention about the vaccination guidelines webinar on the 9th of December from NOBI. So it's 7:30 till 9.
You repeat it, Raja. You do it from your side.
So,
this is another NOBI initiative, which is Raja is going to tell you right now. Please, Raja.
So this is a NOBI Indian Chest Society initiative, which is to talk about the national immunization guidelines for adults, respiratory vaccination, influenza and pneumonia, about which Shelly, myself and Dr. Ghoshal spoke about today briefly. And this would be about after the publication of the guidelines in Lung India, our mouthpiece journal. This will happen on the 9th of December. And it will happen between 7 p.m. to 8:30 p.m. A lot of people who were part of the guidelines, the senior faculty, will be a part of this panel discussion. There'll also be a couple of lectures. So please tune in. Please listen to it. Dr. Ghoshal will moderate a panel discussion in which various aspects which were not discussed in great detail in the actual article will be discussed, and there'll be clarity about vaccination in all groups of respiratory patients and others with chronic disease.
So to conclude, I thank Lupin team, Hirak, Raja, Hoses, Mayur, Abhijit, and everybody, and particularly the delegates, the registered delegates. Actually, you are the encouragement for us. So as we get the feedback, we like to have feedbacks. So please send your feedbacks to Lupin team. We'll be ready to accommodate and do it better every time. Every time it will be better. Thank you all. And
thank you, sir.
very good night. Thank you.
Thank you. Have a wonderful evening. And my sincere thanks to all the young pulmonologists who has attended the program. And the program is really gaining a momentum. Thanks a lot to the entire NOBI team, Dr. Ghoshal, Dr. Rajadhar, Dr. Shaili Shamim. Thanks to the backup team. Thanks to Mayur for conducting everything. Thanks a lot, sir.
Thanks, everybody. Have a good night.
Thank you very much, sir. Have a nice time, sir.
Thank you.